Good morning, clinical problem solvers. It's Tuesday morning slash afternoon slash nighttime, depending on where you are, and it's neurology morning report. And we're excited to have you here. I see Ori, who was going to present a case last week. Did you want to present your case this week? Amazing. Excited for that. And so we will just need two discussants, ideally one identifying as a man and one identifying as a woman. Who would like to discuss today? Dhruv is eager and first in line. I think you have discussed recently, so happy to have you. But if others are eager to participate and have not before, happy to have you too. Pariniti, wonderful. Where are you, Pariniti? And I apologize that I don't know based on your name. There you are. Great. Thank you, Pariniti. And anyone like to discuss with Pariniti? Dhruv, we're happy to have you, but I think you just discussed, was it last week or the week before?
I think it was on student VMR.
Oh, is it on student VMR? That's right.
Yeah.
Okay. Anyone else who hasn't gotten a chance before to discuss, like to discuss this case with Pariniti and myself? Anyone who's been thinking, I've been waiting, I've been enjoying. I think maybe next time I'll try. We'd be happy to have you. Anyone like to join Pariniti? We all like to hear Dhruv discuss, I agree. But if you were thinking it might be your chance, we don't want you to feel excluded. Anyone? Anyone interested in reducing their neurophobia actively?
Oh no.
Next time, Align? Great. Yeah, I know you've discussed before.
Interesting. Kirtan.
Dhruv and Kirtan are, okay. So next time, maybe let's see if others are interested first, and then we always know you'll both be happy to discuss. Great, we have some good news of one of our clinical problem solvers team members, Dr. Gabi Pucci, a neurologist in Brazil, who's always helping us in the morning as part of the NeuroMatch 2022 team, this amazing Twitter effort that was spawned last year during the pandemic, but I think will well outlast the pandemic because it was so useful helping public sort of make sure programs are projecting themselves on Twitter and making sure applicants know where to find information. And I met some students through that who I otherwise would never have met if not for Twitter, who I was able to hopefully be somewhat useful for in their match process. So fantastic, Gabi. Congratulations from your CP Solvers family. And this is just fantastic.
Thank
Great.
you.
Okay, so Ori, Pariniti, and Dhruv, would you like to introduce yourselves and then we'll get going?
Sure. So I'm Ori. I am finishing my MD PhD at Columbia in New York, and I'm starting my neurology residency at UCSF this summer.
Fantastic, future neurologist.
I'm Pariniti. I'm from New Delhi, India, and I have just finished my third year in MBBS, and I am relatively new to the VMR community. I joined this April. So yeah, it's really exciting to be here.
Great, thank you for joining us. What time is it in New Delhi? We're always curious around the world where. Oops, you're.
It's 9:40. It's 9:40
p.m.
Yeah, p.m.
Yeah, nighttime. Yeah, 12 and a half hours from California. Okay, great. Fantastic. Well, thank you for jumping in and participating. And Dhruv, you are well known to this community, but just remind us where you are and what you're about to do in a month and we'll get started.
Well known, but a little bit of a different situation. Currently coming to you on cell phone cam because my computer is currently in the process of being repaired. So and also congrats to Gabi for becoming part of NMatch 2022. I know at least a few of the folks who've been part of NMatch 2021, and they worked so hard during this year for match season, and really looking forward to your guys' efforts coming next year. So, okay, I guess to introduce myself, Hi, everyone. I'm Drew. I am going to be graduating on Friday from VCU School of Medicine, MCV for all the old timers, if anyone old timers in the chat. And going to be heading to Western Michigan University for my medicine pediatrics residency this July.
All right, we will send you in with a little less neurophobia, hopefully. Fantastic. So I think everyone more or less knows how this goes. Ori is going to present us a case that none of us have ever heard about before. And we'll begin with just the chief concern. We'll probably talk about that for a long time. And I realize left my watch in another room, so I'll put my phone here so that you can't see the time on Zoom. And we will discuss together, and then we'll take it step by step and see how we arrive or do not arrive at the final diagnosis. Great. So Ori, if you want to give us just the chief concern in as few words as possible, and then we'll begin our discussion.
Okay, so unwanted movements of the arm and leg.
Unwanted movements of the arm and leg. Great. So Paranithi, what comes to mind when you first hear these symptoms?
First of all, I think this could be a tremor. And when I think of tremors, basically three things come to my mind. First is a resting tremor, which we usually see in Parkinsonism. Second is an intentional tremor. So basically that goes out to reach something and the limbs start moving. And the Parkinsonism tremor or the resting tremor is also kind of described like a pill rolling movement. And the third thing is the essential tremor, which is relatively benign. And how we differentiate the Parkinsonism tremor from the essential tremor is, I think, on the basis of the frequency. The resting tremor is about 4 to 6 hertz, and the essential tremor is 6 to 10 hertz. Apart from tremor, there could be other movements such as, I don't know, I have read about athetosis and coriform movements, which are seen in Huntington's disease. And another one which comes to my mind is hemibalismus, in which there is one limb moves like dancing like movement. So yeah, that's where I'm at right now.
Great, brilliant discussion, Paranithi. So one category of unwanted or involuntary movements would be movement disorders. There are other possibilities, but I think that's where many people's minds would go. And you talked about the hyperkinetic movement disorders. So there's tremor, which you gave us a beautiful description of. There is chorea, which are sort of dance-like movements like choreography. There is ballism and athetosis, which are sort of in a spectrum of chorea, athetosis being sort of milder, chorea being more dramatic, and ballism being very dramatic, abnormal, sort of irregular movements. Other things in this category of hyperkinetic movement disorders include myoclonus, which is more of a twitch or muscle jerk. Dystonia, although you would think of it as a fixed posture, is considered a hyperkinetic movement disorder since it's excess movement. And then tics, as can be seen in Tourette's syndrome. So this is one category of involuntary movements, which is what we call movement disorders. And these are generally categorized as hyperkinetic or hypokinetic, and hypokinetic refers to Parkinsonism, though the tremor doesn't fit into that aspect. And movement disorders are interesting because we often first start with our localization, right? In neurology, and with movement disorders, some of them localize specifically, but most of the time what we're trying to do is really figure out what movement it is, because these can be hard to distinguish in practice. Is this a tremor or a myoclonus or a chorea? Because once you figure out what the movement disorder is, they each have their own differential diagnosis of whether there's a possible structural lesion, a primary neurologic disorder, a systemic disorder, or particular medications. So once we figure out what the movement is, we have a particular differential that falls into those general categories, but with specific instances for each. And just for fun, even though we don't know what these movements are, you picked up on a couple of things that we'll just make some teaching points on. You very wonderfully said Parkinsonism and not Parkinson's disease. Why did you say that? And I think it's excellent. So can you explain why you said that?
So there are some Parkinson plus syndromes, which initially manifest as movement disorders, such as we have Lewy body dementia, progressive supranuclear palsy, and corticobasal degeneration. So they can be differentiated from Parkinsonism Parkinsonism. There are other features to differentiate each of these diseases, but initially they present as either tremors or movement disorders. So yeah.
Perfect, right. So when we think of Parkinsonism, we think of Parkinson's disease, by which we mean idiopathic Parkinson's disease most common in older individuals, slightly more common in men. That's characterized by a unilateral resting tremor, which Pariniti told us about, can be this sort of pill rolling, typically unilateral or at least asymmetric, rigidity, bradykinesia, and a slowed and difficult gait are sort of the main motor features. But that constellation of symptoms, although you can see it in Parkinson's disease, falls under a broader umbrella of Parkinsonism, which can be seen in Parkinson's disease, the so-called atypical Parkinson's syndromes, or Parkinson's plus syndromes, which Pariniti mentioned. Those are multiple systems atrophy, progressive supranuclear palsy, and corticobasal syndrome. Dementia with Lewy bodies can also be considered. They are conditions that have Parkinsonism, but also have other aspects, which we can discuss if they become relevant in this case. And then drug-induced Parkinsonism is a very important category as well. Any dopamine blocking agents, so antiemetics like metoclopramide, antipsychotics, more common with the first generation, but still occur with second generation. Valproate is another one people often don't think of, but I've seen a few cases of valproate-induced Parkinsonism as well. So when we see the Parkinsonian syndrome, we want to realize there's a differential diagnosis for this. And Parkinsonism can also be seen in a lot of other neurologic disorders, and rarely with even ischemic lesions of the basal ganglia. Okay, great. Fantastic first pass discussion here, Pariniti. Dhruv, what are your thoughts here? So let me ask you this. We have involuntary movements. We have movement disorders as one sort of category of things that could cause involuntary movements. Any other thoughts on what could cause involuntary movements?
I guess I'll start by just adding on a little bit to some of the movement disorder thoughts that we've had. So I guess just other unusual causes of things like chorea. So if the patient has had a strep infection, they can develop in very severe cases something known as Sydenham's chorea. This is more common in kids, but it's essentially inflammation of the brain that leads to choreiform movements. And sort of there's a thought that that pans pandus, the neuropsychiatric disorder in pediatrics that usually occurs after strep infection or mycoplasma infection, that disorder is sort of a milder form of Sydenham's chorea. There's also, and I think you also mentioned sort of drug-induced Parkinsonism, and one of the other causes that I think should be mentioned as it's an important basic science cause, but also is important for patients who take, let's just say, not pharmaceutically made recreational drugs, is MPTP, which is an analog of meperidine or Demerol. And that is well known in the basic science world to cause the death of dopaminergic neurons in the substantia nigra, which leads to Parkinsonism. In terms of other things that could be causing unusual movements, I'd probably put stroke a little bit lower down the differential, although you could still have unusual movements that way. Any of the encephalitic syndromes, or maybe even like a meningitis gets very severe, could cause it. I'm sort of thinking more of like inflammatory disorders like infection or autoimmune diseases. Seizures actually is another big one that could cause involuntary movements that the patient may not necessarily know are happening, but other people are saying, "Oh, the patient is moving," and that they're not aware of it.
Great.
Could be myoclonus. It could be atonic or like a drop seizure. It could be tonic-clonic movements. I know the chief concern was specifically for the arm and leg, but it could be sort of we could be dealing with, say, a focal tonic-clonic type of seizure that we're here. So Yeah. At this point, the only thing that we don't have is time course. And if it's chronic, we may start thinking of things like the movement disorders, as they tend to have a little bit more of a chronic time course. If it tends to be intermittent and occurring in spurts, we might think about seizures as a possible cause. If it's acute, we might think of something like an infection or even some sort of an autoimmune flare. If it's subacute, it could even be a mass lesion, like a malignant tumor that could be causing this.
Great, excellent thoughts. Right, so we have a few other things to add to our list of rare causes of Parkinsonism, right? MPTP, which is from synthetic opioids. You reminded me also of very rare causes of Parkinsonism. We can add manganese, heavy metal exposure, and some pesticides, but less common. So you're making me a little dizzy, Drew. Basically, if you don't mind. Just being silly. Right, and the other, so overall, involuntary movements, right, we talked about movement disorders, and then Drew mentioned the important one of seizures, right? So seizures are another cause of involuntary movements. The patient may be aware of those if consciousness is preserved, such as in focal seizures with preserved consciousness, though would not be aware of the movements generally if this was a generalized tonic-clonic seizure, and those would be observed by others. And then another category just to keep in mind, depending on what we hear about from Ori when there's a description of these movements by the patient or the bystander, is fasciculations, right? Maybe these abnormal movements are just small movements of the muscle fibers themselves that aren't large enough to actually move the muscle the way myoclonus is, but are little lightning-like twitches in the muscles that most people would associate on the USMLE step 1 with ALS, right? But those are just a lower motor neuron finding from any cause of motor nerve disease, neuropathy, for example. And for those of you who text a lot and do a lot of email, you might see a few fasciculations in your thenar eminence. And I get a lot of consults, those for worried physicians and medical students wondering if they have ALS. They've seen some fasciculations. And I don't usually do this, but in this case, I hold up my hands and say, yes, all of us using a lot of, I have some fasciculations in my hands too. So we're going to want to know about the semiology of these movements. What do they look like? Is this a movement disorder? And if so, which one? Or are these just muscle twitches and we're thinking about fasciculations? Or are these seizures? And then we're going to want to know, whichever these are, about the distribution. So if these are movement disorder, are they unilateral, which would really make us think of a structural lesion, although Parkinson's disease and corticobasal syndrome often present unilaterally. Are these bilateral, which would make us think of a systemic cause or underlying neurologic condition? Similarly with seizures, if these are unilateral, that's going to make us think of a focal lesion causing those seizures. If they're bilateral, it could be a focal lesion with rapidly generalized spread of epileptic activity, or it could be that there is not a focal lesion and this is a generalized epilepsy or generalized epilepsy syndrome. Then similarly with fasciculations, if they're widespread, we'd be worried about some underlying disease of the motor nerves. If they're in a particular location, we'd be worried about disease of a particular root or nerve. So those are some initial thoughts. What kinds of movements are these? And then where are they located? And then as Drew said, we'll want to know the time course, because if you saw sudden onset of a movement disorder, you'd really worry about a vascular cause. The classic one is hemibolismus from contralateral subthalamic nucleus, stroke or hemorrhage. Again, very popular on the step. I think I've only seen one case in real life, but popular because we understand that mechanism, that you knock out the subthalamic nucleus, you decrease excitation of the globus pallidus internus, which was supposed to be inhibiting the thalamus. And by reducing that inhibition, you release excess motor activity. And where if it's acute to subacute, we worry about infectious or inflammatory etiologies, and chronic, maybe a degenerative cause. Okay, great. I think we have wrung everything we can out of these 5 or 6 words that Ori gave us. Tell us a little bit more about the history.
Yeah, that was great. Okay, so this is an 81-year-old guy. And about 2 months prior to the admission, he noticed that he had left leg shaking and what he called wobbliness. And then this progressed to his left arm and subsequently to his right arm. And he then also noted that he was having trouble sitting up in a chair and like staying stably sitting up. These are episodic. They happen many, many times a day. And Perhaps and I can wait for the exam to give you more of a detail on what the movements look like. But they were impairing his everyday activities. He worked with his hands and was no longer able to work. He had no other neurologic or like focal neurologic symptoms. He didn't report any infectious symptoms or any change in weight or anything like that. Let me give you a little bit more, fill out a little bit more on the left side. Okay, so his past medical history notable for hypertension, hyperlipidemia, and hypothyroidism, which was actually diagnosed just 6 months prior to his arrival. He's on metoprolol, losartan, a statin, and Synthroid. He has no relevant family history. His social worker is that social history is that he lives at home. He's independent in his ADLs and IADLs. He was working until the month prior. He denied tobacco, alcohol, or drug use, and he had no allergies.
Great. Couple of oh, well, let me ask you, Paranithi, you're up. Before we discuss this, clarifying questions you have? I have a couple, but do you have any?
I think for like exposures, like you said, manganese toxicity can also cause shaky movement. So like for the exposures, I guess.
Okay, any other exposures, Ori? And then I have a few questions also. No, okay.
No,
Ori, I know you want to tell us what it looks like when we get to the exam, but just as far as the history, and obviously with movement disorders, we're all also doing the exam during the history because we'd be watching. But did he describe whether these were movements that were there when he was at rest? These are movements that were there when he tried to do something, or both? And did he mention whether there was a sudden onset of noticing this, or it sort of crept up on him over the last few months? And you mentioned that it spread, but the initial onset of the first symptom.
So the initial onset of the first symptom was, I guess, sudden in the sense that like these were episodic events that then happened and then they would stop, and then it spread, as you mentioned. And then in terms of your first question, so these were like they could happen at rest, but they were also like reliably triggered by action, I guess is the way I would say it. Sorry, there are some dogs in the neighboring yard going at it.
No problem. Okay, so these were episodes. They would come on abruptly, last for some time, and go away. And when they came on, they could happen at rest, which didn't bother him, but they mostly he noticed them when he tried to do something. Is that right?
Yes.
Got it. Fantastic. Okay. What do you think, Paranithi?
So first of all, looking at the patient's age makes me think in the terms of sort of neurodegenerative disorders because he's quite elderly. Also, when Ori described the symptoms, he also said that the patient has difficulty in sitting up, which makes me think about sort of a muscle lesion because he's having proximal muscle weakness. So the shakiness could possibly be fasciculations, and this we could relate it with the muscle weakness. And also the family history is absent, so my differential for Huntington's would probably go down the line because Huntington is essentially, I think, autosomal dominant disorder. Also, he is hypertensive and hyperlipidemic, so probably some infarction in the brain, small infarction in the brain could be causing these movement disorders. I'm also wondering if, along with the hypertension and hyperlipidemia, he has diabetes because I know hyperglycemia, hemibilismus, they occur together. So yeah, this is where I'm at. I'm not exactly able to understand the nature of the tremors, but yeah.
Yeah, great thoughts. Yeah, it's a sort of not a clear picture yet what movement disorder this is. And with movement disorders, I do a lot of teleconsultations where people write to me about a movement disorder, and I say, I really need to see the video, right? A picture is worth 1,000 words, and a video is worth 10 million words for a movement disorder. So we would be really interested during this history of observing the patient, because as so far we haven't heard something that sounds like a tremor. Usually patients will use that word or tell you it's shaking. Did say the leg was shaking, came on and came off, but that it's sort of triggered by action. It doesn't sound choreiform. Patients won't say it looks like dancing. Actually, a lot of patients with subtle chorea won't notice they're doing it, and others will notice it. Doesn't sound like a forced sort of twisted contraction like a dystonia. Doesn't sound like jerking like a myoclonus. So not entirely clear what it is. I agree with you. When I first heard shaking and imbalance and triggered by action, well, I'll stop there. Shaking, imbalance, and triggered by action. Does that make you think of anything, Paraniti?
Could it be ataxia? Like
Yeah.
imbalance makes me think about ataxia.
Yeah, exactly. So what if that shaking is, as what you called earlier, an intention tremor, right? An action tremor that's worse with intentional movements, right? Essential tremor is an action tremor. It's worse with action, but it's not imprecise, whereas the ataxic tremor is one of intention that has dysmetria, right? It gets more inaccurate the closer to the target. So is he describing some ataxia of that left leg that he would sometimes notice it shaking when he was moving around and trying to do something? And also that caused the imbalance. And you mentioned he was having trouble sitting up in a chair, and you wondered if that was a muscle disorder from proximal muscles, which is a great thought. What I wondered in that context is whether that is truncal ataxia, whether the patient has ataxia of the trunk. If the movement disorder, some people classify ataxia as a movement disorder, is indeed ataxia. So that's one possibility. And then another thing that I was thinking was, what about this progression from the left leg to the left arm to the right arm? Dhruv or Paraniti, any thoughts on that? Does that mean anything?
It's sort of ascending in fashion. So I would be thinking of pathologies which sort of ascend, but not in the terms of weakness. I know like in Guillain-Barré syndrome, there is ascending paralysis, but this shakiness ascending, I haven't heard of.
Yeah, great thoughts, right? Ascending, we would think legs and then arms, like in Guillain-Barré. But this is one leg to one arm to the other arm. Dhruv, I see you're unmuted. Any thoughts there?
Yeah, I guess the fact that he has that he's having this sort of shakiness with movement. At this point, I'm honestly would want to see exactly how it looks. The hypothyroidism is interesting, actually, and because it can manifest itself with muscle weakness, and these could be fasciculations due to it. I mean, he was just diagnosed 6 months ago. He probably has only had one check of his thyroid function since then, and he's probably due for it again. Maybe he's on too low of a dose of his Synthroid, and it needs to be upped. Especially if this is occurring within 2 months of presentation.
Right. Yeah. What to do with that hypothyroidism? It seems like everyone over age 70 or so is diagnosed with hypothyroidism and is on levothyroxine. I don't know, maybe an internist can tell us, or if we have an endocrinologist or a future endocrinologist, whether there's just a normal decline in thyroid function with age and we're over treating this. I don't know. If you told me that he had anti-TPO and anti-TG antibodies, and that's why someone thought he was hypothyroid. Hashimoto's encephalopathy, a condition that's probably going to go away as we discover all these antibodies and figure out that that was just a broader name for multiple disorders, can present with ataxia, but I wouldn't expect it to be so focal. So when you hear that pattern of, let's take the shaking out, leg to arm to arm to leg, or arm to leg to leg to arm, so-called around the clock pattern. For weakness, that's a pattern that can be seen with lesions at the cervicomedullary junction, because the arm fibers of the corticospinal tract actually cross slightly superiorly to the leg fibers. And if you have a lesion there that's growing, like a tumor at the foramen magnum, you can sort of sequentially affect those the limbs, and you can get the rare syndrome of a triplegia, or you can get a called around the clock weakness. You can also see that in ALS sometimes, that sort of spread limb around the clock. But this is shaking, and Drew made the good point, is this shaking because the patient is weak, right? If you try to lift a really heavy weight, right, or if you try to do a core workout, your abdomen shakes, right? And so is this just weakness? And so that's why it's worse when he moves. That's possible. And then the other thing that can cause unilateral shaking, although it shouldn't be bilaterals, you can get something called a limb shaking TIA, which is usually with carotid disease, where the patient will have, it's probably shaking due to weakness. I'm not sure the actual mechanism is known, but the patient has episodes of limb shaking from a diseased carotid on that side. But that would explain if it was all left-sided episodes, and maybe with, if he was orthostatic or something like that, that it's exacerbated. But if it's on the right also and just in one limb, it suggests that something is moving around. So I don't know if you could have an around-the-clock cerebellar lesion where you had sort of a tumor sort of towards the midline off to the left of the cerebellum, getting the left limbs and growing and getting the trunk, and then coming over and getting to the right side of the cerebellum, something like that. But as far as the semiology of the movement, it is starting to sound like ataxia. As far as it being movement induced, there are conditions, I've never seen these, I've sort of always wanted to see them because they sound so interesting. There are conditions called the episodic ataxias. These are on what I call my neurology bucket list of conditions I've never seen and hope to one day see. I've never seen Wilson's, never seen Whipple's disease causing neurologic dysfunction. And that list includes the episodic ataxias, which are genetic syndromes that cause episodic ataxia. Presumably would have presented younger, but I don't know that much about them except that they sound cool. And then there's a group of conditions called the paroxysmal dyskinesias, and there are kinesiogenic dyskinesias and non-kinesiogenic dyskinesias. I've never seen these either, but they sound really interesting, where patients get dyskinesias, or sort of choreiform movements that can be triggered by exercise. Those are paroxysmal kinesiogenic dyskinesias, which just sound cool, and I've never seen them. And Ori is at Columbia, where there's an amazing movement disorders department with people who wrote all the big textbooks where I learned all of this stuff. So maybe he's going to present us a very rare case. But at this age, and with this sort of very rapid progression, it would be hard to imagine a genetic condition. I think people mentioned degenerative cause. This seems a bit fast for that for me, and not clear what degenerative cause that would be. There is a variant of multiple systems atrophy called MSAC, where there's predominantly cerebellar features, as opposed to MSAP, where there's predominant Parkinsonism. Usually there's a lot of autonomic dysfunction as well, which we haven't heard about. So in a person of this age with lateralized neurologic findings and these risk factors, if it was sudden, we would have thought of stroke, but this doesn't seem to be behaving like stroke unless he's having recurrent small strokes, but then all causing the same symptom in separate limbs seems a bit of a stretch. But I would also worry about malignancy, particularly metastatic malignancy. He doesn't have any particular cancer risk factors aside from age, but whether there's some metastatic posterior fossa lesion that's expanding and causing these symptoms to spread from place to place. So I don't know. We're still, I think we still don't know what the movement is, which is hindering us a little bit, but I think the age and the progression over months sound sort of subacute, but I guess the episodic aspect would take us away from some of the etiologies I mentioned, again, unless the episodic nature is because this is ataxia and the episodes are because he's moving, but still not entirely clear. So I think we're going to be really interested in the exam, which would have begun in the waiting room, right, to just see what this movement is, and then we'll be able to dive deeper on our differential diagnosis. So what did you and your colleagues find when you examined this patient, Ori?
Cool. So let me just give you a quick outline for the rest of the case. So we will have 2 more media aliquots, and then there will be the final test. Okay. So so this patient initially presented to an outside hospital, and I'll give you the exam from the outside hospital. So the vital signs were all normal. We actually don't have anything written down, but they were normal. And orthostatic vital signs were normal as well. A systemic exam was normal as well. I won't read it all to you. His mental status was completely intact. He had clear speech. His cranial nerve exam at this time was notable for ocular overshoot when he was following the fingers. His motor exam, so here's where I'll describe the tremor. So this was described as a wing beating tremor. And perhaps I can just mention what it looked like. So if you would ask him to, for example, reach towards your finger for finger, nose, finger, he would then have wild beating movements of the arm. They could also be triggered by touching or like pinching the contralateral side. So there was like a little bit of kind of action-induced aspect. And then they could also happen randomly. So you would be talking to him, and then all of a sudden, one arm would start flapping. The motor exam, so obviously difficult to test strength to confrontation when he has kind of an action-induced movement. But he had normal tone and normal bulk on his muscles, and no obvious weakness. His sensation was normal. The reflexes were normal, except for plantar reflexes that were upgoing. He was unable to walk, and really dysmetric in all tests. So unable to do finger, nose, finger, unable to do heel to shin, and also unable to do rapid alternating movements. Okay.
Unable to do as in?
It was just like it's so the finger nose finger had like overshoot, but it's just like confounded by these kind of these beating motions. Let me give you some labs and one set of imaging, and then that will bring us up to his transfer to Columbia. Okay. So serum tests were uniformly normal. So yep. These notably included serologies, so HIV was non-reactive, RPR was negative, a rheumatoid factor was negative, Rho and La antibodies were negative, and an SPEP was negative. An LP at the outside hospital had a normal opening pressure, no whites or reds, glucose of 62 and a protein of 41, which were both in the normal range. And then CSF serologies or CSF antibody tests, notable for negative Lyme immunoglobulins. Our like CSF meningoencephalitis PCR panel was negative. Cytology and flow cytometry didn't show any proliferation. Cultures were negative, and a paraneoplastic panel sent to Mayo was also negative. He had an MRI, which showed a flare hyperintensity in the right superior parietal lobe without contrast enhancement.
Awesome, thank you. Great presentation, Ori. You're ready for prime time, but I hope you take a break before prime time, July 1st. All right, Drew, we're back to you. What do you make of this exam? What is the movement disorder?
Oof. Yeah, just my audio not working right.
No, I think it's okay.
Okay. Because my computer just got fixed. Since the just decided to I think it like for some reason. But anyway, that wing beating it seems interesting that it would be it's both action in that it's tremor as well as an action induced. Yeah, like I'm starting to think of being an issue like looks like hemibolismus to me, but the fact that it's sort of in multiple limbs is sort of is confusing me. What else? And then in terms of his and otherwise normal, I think the only other thing would be the ocular overshoot when testing his extraocular movements, but I don't know if I do not think that it's a visual problem leading to a motor issue. As for the labs, Hyperintensity in the right superior parietal lobe. No contrast enhancement. All the rest of it negative. I mean, it could be an old stroke, but this does not look like stroke semiology to me.
Yeah, good. Fantastic.
I mean,
yeah.
the only other thing that I could think of is probably like it be like an inflammatory flaring syndrome of some sort. But even then, MS would be, this patient be too old for MS, too old for NMO, and I'm still racking my brains just trying to figure out what this could be.
Yeah, great discussion. So yeah, when you hear wing beating tremor, I think that buzzword for us on our neurology board is Wilson's disease. And I think it's meant to describe, you can correct me if I'm wrong, or you have some of the best movement disorders people in the world around you, that when you ask the patients to put their hands like this, that the wing sort of arms start beating like wings. But Wilson's disease, again, I'm still waiting for my first case, but I think it's
Yeah.
Okay, so I think, and Wilson's disease generally presents much younger, and I would have expected it to be more symmetrical. So what are those movements? They certainly seem large in amplitude. There does seem to be some cerebellar features here, right? There's the ocular overshoot, though we didn't hear about nystagmus. We didn't hear about dysarthria, which are other common cerebellar findings. And it's unclear, it sounds like from this exam, not unclear from Ori's presentation, but unclear examining this patient, right? If there's this movement disorder, is there also imprecision and inaccuracy of movements? And that's due to the movement disorder, or is this ataxia? If the patient is having these spontaneously at rest, those would be less suggestive of ataxia, which is a disorder that is sort of movement induced, right? When you're trying to do a precise task, that is when the movement comes out. So I'm not sure. It's high amplitude, which could make us think of bulismus. But that spread of bulismus from one side to the other would be somewhat atypical. The way Ori was demonstrating it, if that's what it looked like, doesn't fall into a clear pattern for me, where I said, oh, it looks like he's, imitating ataxia, or he's imitating chorea. It's too large amplitude for myoclonus. So this is somehow how we sort of think through these movement disorders, looking at it. Is it this? Is it this? Here's why it's not this. Here's why it's not that. I hadn't mentioned it before, but if we thought this was ataxia, getting a paraneoplastic panel is important, because a subacute ataxia in an older person over 60, sort of paraneoplastic cerebellar degeneration is one of the top things on the differential. In women, most commonly ovarian or breast. In men, you would think of lung disease. Anti-Yo being one of the most common antibodies. So if this is ataxia, we would have a particular differential diagnosis, but I'm not sure this is ataxia. And one thing I'm wondering, again, just looking at Ori's, the way he showed us the movements, and just this sort of very atypical progression kind of around the clock here, is when you see a movement disorder that doesn't fit into any clear pattern, and sort of it's not really fitting into a sort of rest, movement disorder or action. It's not really looking like chorea or ataxia or any of the others. We do have to consider the category of functional neurologic disorders as compared to structural neurologic disorders. These were previously called psychogenic disorders, but the underlying pathophysiology is more complicated, and that is a sort of stigmatizing way of describing them. And they are functional, meaning we don't see a structural lesion on neuroimaging, but there is a movement disorder, and it is disabling to patients. And so when I see a movement disorder that doesn't fit into a clear pattern, I have to wonder, is this a functional neurologic disorder, which often have underlying psychological trauma or history related to that, but not always. And so things you can do on the exam to try to tease this apart are to look at whether there's a lot of changing in amplitude and frequency of the movement, whereas most movement disorders, from structural etiologies, degenerative etiologies, et cetera, are more consistent in an individual patient as far as their frequency and amplitude. You can do distraction maneuvers. So if you have the patient do this with one hand and the tremor goes away with the other hand, or the frequency sort of entrains, or if the movements get worse, the more you, Ori mentioned he touched one limb and the other limb got worse, that can be a sign of a functional movement disorder. These disorders are very difficult to diagnose. But when it doesn't really look like anything you can recognize, and you have sort of thought of all the things it could be and it doesn't fit, that's something to wonder about, and whether there's any relevant recent history, although there isn't always, in terms of this patient just have a bad accident, a death in the family, something like that. So that has entered into my differential here, but we're eager for the next exam at, with Ori and his colleagues here.
Okay, at the outside hospital, he also received 3 days of high-dose methylprednisone because of concern of a paraneoplastic syndrome, and it didn't affect the tremor. He also empirically received clonidine and Sinemet due to concern for a movement disorder, and also no change in the symptom. So this is when we saw him. Movement disorders was actually got an inpatient consult, which I had never heard of before, and also felt like pretty much had the exact same comments that you did, Dr. Berkowitz, which was that they couldn't really characterize this into one of the classic movement disorders. So at this point, we had no idea what was going on. We hooked him up to EEG, which showed a pattern that was consistent with epilepsia partialis continua, which we can talk about in a bit. He then received Ativan and Keppra. He was post-ictal with weakness in all three of the affected limbs. And at that time, he became less awake, and I would say that his mental status declined fairly dramatically. After the Ativan washed out, he kind of woke back up a little bit, but then still had a depressed mental status. He began to complain of dysphagia. He was agitated, and overnight actually was suicidal several days after starting the Keppra. I think I'll stop there. Oh, and I'll just also mention he got IVIG empirically, which had no effect on the symptoms.
All right, Paranithi, what do you make of this new information here? And then the next aliquot will be the diagnosis. Is that right, Ori?
I'll give you some more, and then you guys can make a final.
So you don't have to make a final wager yet, but we should be moving to our what test would you get next, and what are you still thinking about here?
The fact that it did not respond to any medication also makes me think that it could be a functional disorder. Like you mentioned, catatonia usually presents in this way, like when you're not able to characterize this movement disorder. But the fact that the EEG shows epileptic changes, I am wondering if there's a phenomenon called Jacksonian march, where one of the limbs starts moving and slowly it sort of spreads to the other body parts. So maybe this is what is happening to the patient. And the hospital stay, the fact, I don't know what salt is there in the medicine Keppra. I know Ativan is a benzodiazepine. So I don't think it could be. Oh, okay, anti-seizure med. Okay, so I don't know if any of these should cause the dysphagia or the suicidal tendencies or agitation. So right now I'm slightly, bending towards the psychological, it's a neuropsychiatric problem maybe, because a patient turning dysphagic and suicidal so suddenly makes me think like that. Or it could, yeah, that's it.
Yeah, great thoughts. I think we were all surprised based on facial expressions and otherwise that these turned out to be seizures. Early on our differential, right, we said abnormal movements could be movement disorder, seizure, or fasciculations of muscle as some broad categories. But gee, these didn't sound like seizures. And the Jacksonian march you wonderfully described is usually marching along the motor cortex or somatosensory cortex. So it's marching along one side, face, and then arm, or something like that. So sort of marching over to the other side I'm not sure if that's what Jackson described, but I haven't looked at the initial description. That's possible that this is just either multifocal seizures or seizures that are traveling around. But gee, was not expecting these to be seizures based on the description. And yeah, Ativan to an older person can have a paradoxical reaction of agitation. So, and Keppra or levetiracetam, very commonly used anti-epileptic, can have the side effect of irritability, anger, personality changes, suicidality, depression. So those are probably medication effects, as you said. So if we really have an 81-year-old with new onset epilepsia partialis continua with no lesion on MRI, that is sort of the problem representation as I would think of it. And what is that, right? Non-lesional multifocal epilepsy, new onset in someone in their 80s. I would really probably think of an autoimmune or antibody-mediated condition. This is very severe, very abrupt in onset, and very atypical. And if you have new seizures, either there's a lesion causing them or there's not. And in younger individuals, if there's not, you think of genetic etiologies. And or in older individuals who've had more time to live and acquire prior strokes, prior head trauma, prior meningitis, or a tumor, you would think of those structural etiologies. But this is epilepsy, new onset, no lesion, this age. I would think of an antibody-mediated syndrome, which may be paraneoplastic, but may not be. Although usually those are accompanied by the whole sort of constellation of limbic encephalitis, which we're not hearing about here unless it's being unmasked by these medicines, but it sounds more that these medicines are causing it. And I suppose the only other thing to keep in mind, since Ori's colleagues looked at this patient and said, this looks like a functional movement disorder, not one of the classic movement disorders, is the EEG correct? Because the EEG is a challenging test to interpret. If this patient is moving around a lot, there can be lots of artifact. I'm going to trust, they have some of the, again, the highest expertise in our country in epilepsy at Columbia. So I'm going to trust that EEG read, but something else, if this really didn't look like it made sense, would wonder about, are we sure on the EEG? Are we seeing some type of muscle artifact from this patient bouncing around in the bed with these large movements? So I'm not sure. What test would I do next? I guess we'd probably repeat an MRI and just see if there wasn't anything there before. And now we see what? We wouldn't see a mass suddenly. We wouldn't see a bunch of strokes if we hadn't seen any before. Could the first scan have been normal and the patient has Creutzfeldt-Jakob disease, and now we're seeing the cortical ribboning, which was missed on the first scan. There is a Heidenhain variant that can present with cerebellar ataxia. You can see seizures. No, I'm sorry, Heidenhain variant is a visual variant. There's an inherited form that can present with cerebellar ataxia called Gerstmann-Straussler-Schenker. He's too old to be presenting with that, I would imagine. But to see CJD can present essentially with anything. Is he presenting with anything and just the first MRI was either undercalled or the cortical ribboning wasn't there yet? So I would probably re-image him. I would keep him on EEG and make sure we all believe that that's what's going on. And then I would be worried about an antibody-mediated syndrome. I know that was looked for, but if it was just the paraneoplastic cerebellar panel, we wouldn't have gotten the encephalitis and epilepsy panel. I would think of sending that and probably think of either a PET or a CT chest, abdomen, pelvis to look for whether there's a malignancy driving non-lesional new onset epilepsy in a person of this age. So what did you and your colleagues do next, Ori? And then take us up till the almost final, we'll read your diagnoses and then you can tell us.
Beautiful. Okay, so CT, chest, abdomen, and pelvis didn't show any concerning masses. So at this point, he became more and more somnolent. The EEG showed slowing, and which was predominantly right posterior. He began to have rhythmic twitches and stimulus-induced myoclonus, and he was intubated for airway protection and brought to the neuro ICU. He had a generalized tonic-clonic seizure there a couple days later. He had a repeat LP with a number of send-out tests that were pending, and an MRI which showed cortical remitting in the right insula and parietal lobe, an EEG with triphasic waves, and then he was empirically given plasma exchange, again with no improvement.
That's and then you muted yourself deliberately. There's nothing else to tell us. Yeah, okay.
So the guys can ask for the final test and wager at this point.
Okay, just making sure we didn't lose you there for a second. Okay, cortical ribboning in the insula and parietal lobe on one side. Is that right? Yeah. Okay. We are at time. We have a minute left, so just short take. What is your one or two top diagnoses, and what test would you get to try to take it over the finish line, Drew?
Creutzfeldt-Jakob, get 1433 from his CSF, and the awful way to end the case if this is the diagnosis.
Yeah. So, what made you concerned for that CJD? Was there something clinical, or the buzzword, or a particular buzzword?
I think as soon as you mentioned the cortical ribboning, and as soon as the I guess the other thing too was that he had this sort of rapid progressive movement disorder that when you it sort of looked like he was, I don't know if it looked like he was in focal status, and when they gave him Keppra and Ativan that it eventually sort of unmasked everything, or if it was just a coincidence. But as soon as, I think the other thing too was the triphasic waves. I think that's also characteristic of Creutzfeldt-Jakob disease, and not a nice way to go, unfortunately.
No. Okay. Right. So cortical ribboning is a buzzword for CJD. It is not unique to that condition. You can see diffusion restriction in the cortical ribbon from seizure itself. So this may be signal change from seizure causing cytotoxic edema. You can see diffuse cortical ribboning after hypoxic ischemic injury. Obviously, the clinical context there is that the patient has just had a cardiac arrest and is comatose. That's not the context here. And a small stroke just affecting sort of one region of cortex could look like that also. So if this is really just on one side and kind of a few contiguous gyri, no no diffusion restriction in the basal ganglia, less than 3 gyri would not meet UCSF criteria for Creutzfeldt-Jakob disease, but certainly you hear cortical ribboning, you would think of that. I agree with you, Drew. It's hard to know if there's rapidly progressive dementia here or just epilepsy. The patient had normal mental status when they came in, and then just iatrogenic, Keppra, Ativan, the hospital, right? And this patient ended up with, what looks like a rapidly progressive dementia, but that was medicine, the fault of medications, not the illness. And I'll just mention, you mentioned 1433, that is also correct on the USMLE, but we've learned that there's actually not a sensitive or specific test. And the standard test now is the RT-QUIC, the real-time quaking induced conversion assay, which has such a cool name, which is looking directly for prion protein rather than this non-specific marker of neurologic injury, which can be positive in stroke and herpes encephalitis and all kinds of things, and can be negative in CJD. The triphasic waves also, that is mostly just reflective of an encephalopathy. Creutzfeldt-Jakob, the classic finding is periodic sharp wave complexes, later called lateralized periodic epileptiform discharges, now called lateralized periodic discharges because the epileptologist changed the name of everything every few years. And those are also insensitive, non-specific. So I don't think we have a full package for CJD here. And I think, well, I won't say what I think yet. I'll give you a chance, Pariniti. What do you make of all of this data, and what test would you get next?
What I knew about CJD was the EEG thing, which you said that triphasic waves are, can be found in any encephalopathy. I also know that startle myoclonus is what we see in the patient, and I think Ori also he told during the hospital stay there was a episode of myoclonus. So the only other test which I know is a brain biopsy, which obviously we cannot do on an alive patient. I'm not sure. Can we? I don't know. So what we see on a brain biopsy is spongiform changes, as I know from my pathology. And yeah, that's it.
Great. Great thoughts. So yeah, when you hear startle myoclonus in this context of rapidly progressive dementia, it would also make you think of Creutzfeldt-Jakob disease, but myoclonus has a very broad differential. And the most common cause of myoclonus is just some systemic condition or medication induced. And he certainly has a bunch of medications, and if he stays in the hospital intubated, he may have infectious complications as well, with a Foley and a and being intubated. So I'm not, there are all these things that if we pick them out and put them next to each other, they would sound like CJD. I'm not sure in this case if they add up. That being said, colleagues of mine have told me they have diagnosed patients as having a functional disorder only to find out later they have Creutzfeldt-Jakob disease. And it is a, quote, functional disorder, meaning there is no structural etiology, but the patient has these functional deficits that don't fit into a clear pattern. So this is a disease that can be very protean in how it presents. But still not sure we have everything to add up for that. And I think I'm still thinking of this as non-lesional multifocal epilepsy. And that's making me wonder still about an immune-mediated condition and wondering if everything else has an alternate explanation, that we've given him myoclonus that's drug-induced, that the cortical ribboning is actually secondary to seizure rather than the cause, and that the test that will come back and solve this for us is that antibody panel. Which antibody? There are so many of them now. Ones that present with isolated multifocal epilepsy, I think sort of overlap with the limbic encephalitis. There's a GABA A antibody, a GABA B antibody, usually not associated with malignancy. LGI1 usually presents with faciobrachial dystonic seizures, which are sort of like a little dystonic cramp almost looking like of one arm and one side of the face. Can be bilateral, but usually not simultaneous, though can be. There's also usually hyponatremia with that condition, which we didn't hear about. So what we're still learning about these disorders, and they can present in all different ways. So I'm going to guess CSF was sampled again, maybe not that specific, or I think you already did that and it was pending. So I'm going to bank on one of these antibodies and not CJD. So what happened next, Dory? We're on the edge of our seats.
Okay, so so the clinical conundrum that you just put together of like, did we create this or is this happening organically, was exactly what we were struggling with at the time. And the lack of improvement with kind of 3 stepwise immunomodulatory therapies suggested to us that it was not a immunologic cause. And he actually was made Cumver measured only and palliatively extubated at that time. 2 days later, the RT-QuIC came back positive from the LP. And his family actually allowed us to do a head-only autopsy, which showed spongiform changes consistent with CJD. So for this guy, we have a CJD causing an epilepsia partialis continua, which is very rare. There's only a couple case reports in the literature of this as a presenting syndrome for CJD.
Wow, Ori. Well, I hope there's about to be another case report in the literature. First author, Lieberman O.
Yes, working on it.
Very good. Wow. So yeah, very atypical presentation of CJD, and shows the power of this RT-QuIC test. Although it's a send out and doesn't come back right away, it comes back relatively quickly. Just to come back to your point, Parnitha, you can do a brain biopsy. Obviously for tumor, we do those quite commonly. And then sometimes in cases like this, if maybe the patient was not so severely affected and we thought there was a chance of meaningful recovery and we're really, we don't find anything, we can't figure anything out serologically, we'll do a biopsy of affected tissue on an MRI, but often it comes back non-specific inflammation or something like this can be very difficult. So wow, very atypical presentation of a very rare disease, right? This is one thing I think about a lot. If you're a neurology resident, as Ori is about to be, and as Gabby has just finished, right? You see so many strokes and realize there's so much more beyond left MCA aphasia and right hemiparesis, right MCA neglect and left hemiparesis. You can see all kinds of different things from stroke, and you really broaden your fuzziness around the core concept of stroke. But what about the really rare diseases that can present in so many different ways? We all have our quintessential CJD case, right? Rapidly progressive dementia with myoclonus and cortical ribboning on MRI, right? But CJD is about a 1 in a million, 2 in a million. So, working in very big, very busy tertiary referral centers in Boston with a large catchment area, I think maybe a couple of cases a year across the 2 hospitals. And so when you see something rare, how do you recognize a rare presentation of a rare disease? And I think Ori and his team were trying to do anything they could to figure out if there's a treatable cause here of a very atypical condition. And they were concerned, as it seems I was, for autoimmune conditions, tried IVIG, tried, I think you said, I don't know if you tried plasma exchange, I don't remember. Yes, plasma exchange also, yeah, steroids. And often if there's an autoimmune condition, you'll get some signal that you're moving in the right direction, but not always. And if the patient was sort of awake and this was happening and not deteriorating so rapidly, would we have done a biopsy? That being said, if CJD is on the differential and you're doing a biopsy, all sorts of precautions, you have to incinerate the instruments. The neurosurgeons really don't want you to do that. So it would only be if you thought there's a couple of things we could find that would be treatable that's worth doing this, and all the things you'd have to do related to prion disease. So wow, CJD can present with seizures. I have a talk I give to our residents on rapidly progressive dementia. I forget the number, maybe 10, 15%, not super common, but does happen. But multifocal epilepsy, partialis continua, that even some of the world's best movement disorders doctors thought was a functional movement disorder looking at it. So an atypical syndrome presenting atypically with an atypical presentation of the presenting symptom. This is multiple layers of atypical and challenging. So kudos to you and your team, Ori, for making a diagnosis, for doing everything you could to try to treat what could be reversible, and ultimately helping this family understand that this was not going to get better, so that patient could pass peacefully. And people ask why, do the autopsies. These are really important to learn from these patients, and often people feel very hesitant to ask the families, but especially with neurologic disease, when it's a mystery, I found that many families will actually say, oh, thank you for offering that, and we'd really like to know what this was for closure, because it was just so troubling. And or they say, we really want everyone to learn from this case. And I've even sent write-ups to patients afterwards that or patients' families that we've published, that they are grateful. Obviously not universal and everyone is different, but something we have to sort of learn how to do that feels uncomfortable. But in this case, the diagnosis was made by RT quick, but in other cases where this would have been a mystery, at the end, those autopsies could be very meaningful for the family and for the team. Very good. Wow, what a case, Ori. And you're about to go to one of the world leading expert centers in CJD and prion disease, right? Stanley Prusner, who won the Nobel Prize for prions, is at UCSF, and Michael Geschwin, one of the leading experts as well. I heard a podcast interview with Stanley Prusner recently where he was saying they were trying to figure out the name for what to call these infectious proteinaceous particles. And I didn't realize this, but prion actually stands for proteinaceous infectious particle. And they were trying to find some interesting name that would kind of catch on. He talks about this in these recent interviews in the neurology podcast about his journey to discovering prions and his career and naming prions and winning the Nobel Prize and all that stuff. Okay, wonderful case, Ori, fantastic discussion of a very complicated case, Dhruv and Paranithi, and I will leave it to Chiara to close out with some teaching points.
Hey friends, thank you so much for the amazing case. Unfortunate final diagnosis, but well, we managed to learn a lot, and we had an elderly male with movement disorders at first that we managed to classify them as hyperkinetic disorders or hypokinetic disorders. There are many, and it's sometimes difficult to differentiate them, but in hyperkinetic disorders, we can have tremors or chorea, valism, acidosis, or movement disorders like seizures that can be presented as myoclonus or dystonia or some fasciculations, and even we can have tics with hyperkinetic involuntary movements. Also, we can have hypokinetic involuntary movements. In this case, we can have Parkinsonism, and within Parkinsonism, we can have Parkinson's disease. But we also can have some plus syndromes like dementia with Lewy bodies, or cortical basal ganglionic degeneration, progressive supranuclear palsy, and some others. Also, with Parkinsonism, we can have antipsychotics drugs or metoclopramide or heavy metal exposures that falls in the category of drug-induced hypokinetic movements. And some clinical features that can lead us to differentiate these movements, which is our next phase to go with, is that, in example, a shaking imbalance and triggered with action, we can think that this is an ataxia. When we have an ataxia, we know that most likely can be like a cerebral cause, and we can differentiate it like it with like not a finger to nose exam. However, not every ataxia is confined to the cerebellum. But for example, in this case, we have most likely a subacute onset, and if as this was an elderly male, we have to think more about a possible paraneoplastic syndrome in, like, for example, like ovarian or breast if this was a female. Also, when we have a movement that is triggered by exercise, we have to think about paroxysmal dyskinesia. Another example is like when we have a round clock weakness, we can think about cervical medullary junction disease, or a carotid disease if this is like a limb shaking TIA. Also, with the finding about wings beating, we can see that in Wilson's disease, but this is like a representation, and this is most commonly seen in younger people, and this is more symmetrical. Also, when we have a large in amplitude movement, we can think about like ballism or cerebellar. And also there is a disease like called Jacksonian march, which is like a partial seizure that can spread into the limbs. Also, when we have imagines that is difficult to diagnose because they are not so much relevant, and we have a movement disorder that doesn't fit in any specific time, we have to think about a functional neurologic disorder, and we can differentiate it checking amplitude changes or some distraction maneuvers. And well, finally, approaching this problem presentation as an elderly male with episodic involuntary movements and new onset epilepsy, and without that relevant images, plus this EEG, we had to think about two possible scenarios. One, an autoimmune mediated disorder, probably paraneoplastic because of the age, and another case can be Creutzfeldt-Jakob disease. That was sadly the final diagnosis. And important thing in Creutzfeldt-Jakob is that there is not a good prognostic, even a slightly good prognostic. These patients end with mechanical ventilation or with some other nosocomial infection, and they progress very bad. And yeah, sad diagnosis, but we learned a lot. Thank you so much, Ori.
Great, fantastic summary, Chiara, and thanks again, Ori, for presenting this very challenging case and unfortunate outcome for this patient with this very devastating condition, but fortunate that our group could learn from it this morning in this very atypical presentation, and all the steps along the way to hopefully learn a few things about the approach to involuntary movements and the importance of keeping seizure in the back of your mind, because it can present in so many different ways. So thanks everyone, and have a great day/night, and we'll see you next Tuesday. Bye.